morning, ladies and gentlemen. I welcome you once again on a Sunday morning for an interesting session on approaches to thrombocytopenia and platelet count, practical tips and troubleshooters. It's my honor and privilege to welcome the program director for this series, which we have been hearing from last 2+ years, Professor Dr. M.V. Agrawal, sir. Sir doesn't require any introduction as he's known to all of us. He's president at Mumbai Hematology Group, professor and head Department of Hematology at prestigious Bombay Hospital, consultant at Leelavati Hospital and Rich Candy Hospital. Sir has been inspiration for all of us. It's because of him that we have been able to hear and learn from experts across the globe from last many years. So with this, I hand it over to you to kindly take forward today's proceeding. Thank you so much.
Thank you, Mr. Gopal. Good morning to one and all from India. Good afternoon, good evening from the rest of the world. Our guest speaker today is Dr. Kunal Sehgal from Mumbai. He's going to speak to us on approach to thrombocytopenia and platelet count, practical tips and troubleshooters. This webinar is brought to you by Mumbai Hematology Group. It is supported by INTAS and managed by Perfect Square. I thank Mr. Gopal Rawal, Dr. Manoj Kumar and their team from INTAS, Mr. Kalpesh, Mr. Yash, and their team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest, Dr. Pravas Mishra from Delhi, the guest speaker, Dr. Kunal Sehgal from Mumbai, all our discussants who are themselves eminent hematologists or hematopathologists, and you participants for sparing your Sunday morning or afternoon or evening. Mumbai Hematology Group website is www.mhgindia.com. It gives you all the information about our future webinars and how to log in. It's all complimentary. Make use of it whenever you are free. Saturday evening, 7 o'clock, Sunday morning, 11:30. Spare your 90 to 120 minutes and you'll be educated by the best of the faculty, not only from India, but from the world. Coming Saturday at 7 p.m., we have Dr. Aurav Vishwapandya speaking to us on why are patient safety and quality improvement a must in healthcare. He's from Princess Margaret Cancer Center, Toronto, Canada. And the next day, we have Dr. Regu Sukumaran from TMC Kolkata speaking to us on management of relapsed refractory Hodgkin lymphoma in pediatrics and IA group. And that will be at 11:30 a.m. on Sunday, 7th August. Our discussants today, and there are a good number of them, they've been all displayed here alphabetically. And I'll introduce them to you. Dr. Akshaya Mandloi from Suraksha Diagnostics, Kolkata. Dr. Anjali Kelkar, Lab Director, Ruby Hall Clinic, Pune. Dr. Vijita Datta from ESI, PGI, MSR, Kolkata. Dr. Jasmita Dutt, AIMS, New Delhi. Dr. Jyoti Vijay Savne from GCRI, Ahmedabad. Dr. Jyoti Kotwal from Gangaram Hospital, New Delhi. Dr. K. Gayatri from Lifeline Tapadia Diagnostics Center, Hyderabad. Dr. Nisar Thakkar from Wokad Hospital, Rajkot. Dr. Parimal Sarda from Vedanta, Ahmedabad. Dr. Prashant Sharma from PGI, Chandigarh. Dr. R. Manchanda from KEM Hospital, Pune. Dr. Rajat Jain from Sayadri Hospital, Pune. Dr. Rajani Priya Yedla from Mahatma Gandhi Cancer Hospital Research Institute, Vishakhapatnam. Dr. Rutvi Dave from Department of Transfusion Medicine, Immunohematology, CMC Vellore. Dr. Rama Hariharan from AIMS, New Delhi. Dr. Roshni Shekhar from Manipal Hospital, Bangalore. Dr. Sandeep Sheth from Zydus, Ahmedabad. Dr. Seema Tyagi from AIMS, Delhi. Dr. Sindhura Lakshmi KL from Kasturba Hospital, Manipal. Dr. Shashi Bansal from Bhagwan Mahavir Cancer Hospital, Jaipur. Dr. Swati Pai from Manipal Hospital, Bangalore. Dr. Tara Roshni Paul from Nizams, Hyderabad. Brigadier Dr. Tathagata Chatterjee from ESIC Medical College Hospital, Faridabad. Dr. Tejinder Singh from DRG Unipath Lab, New Delhi. Dr. Tulasi Jiva from CMC, Vellore. Dr. Tushar Sehgal from AIMS, New Delhi. Dr. Udayan Kachi from Vadodara. Dr. Vishrant KS from Manipal Hospital, Bangalore. Thank you for permitting me to introduce the faculty today, the discussants, who are very important personality, and we'll have a great interactive session after the formal lecture. Now we come to the Sunday quiz. As usual, the Sunday quiz answer has to be sent by you to the email ID that has been put up here, mbagarwal1@gmail.com. So today's quiz is related to thrombotic thrombocytopenic purpura. You will be shown 11 statements, of which one is a false statement. 10 are correct, one is false. Each statement is numbered from 1 to 11. The number of the false statement, 1, 2, 3, 11, whatever, you have to email that number to mbagarwal1@gmail.com. Winner will be the fastest finger first, and we will read out names of all those who send us the correct answers, the correct number of the false statement, in the order in which you send it. Okay, so I'll show you the next slide that has 11 statements. Have a look at it, and I will read it out for you as well, and then keep it for 30 seconds on. So statement number 1, acquired TTP accounts for over 90% of TTPs. 2, inherited TTP secondary to mutations in the ADAMTS13 gene may present for the first time during pregnancy. 3, in acquired TTP, in almost 25% of the subjects, antibody to ADAMTS13 cannot be documented. 4, ADAMTS13 regulates von Willebrand factor multimeric size by acting on A2 domain of VWF. 5, in United States, acquired TTP is more common in obese females of Black ethnicity with median age of 4th decade. I'm sorry, there is a mistake here in printing. Median age of 4th decade. Number 6, brain, gastrointestinal tract, and cardiac problems are the commonest clinical manifestations. Number 7, thrombocytopenia is usually severe, with platelet count often below 30,000. 8, as creatinine is almost never very high, unlike in hemolytic uremic syndrome or atypical hemolytic uremic syndrome. Statement 9, plasmic score helps in planning therapeutic plasma exchange until ADAMTS13 level is known. Statement 10, ADAMTS13 level of less than 50% is strongly suggestive of TTP. And the last statement, besides therapeutic plasma exchange, steroids, and rituximab, carfilzomib and recombinant ADAMTS13 are the 2 new modalities of treatment for TTP. So these are the 11 statements. One of these statements is wrong. That particular number from 1 to 11, whichever number, that number is to be emailed. I'll keep this slide on for 30 seconds. Okay. So one of the statement was wrong. Email its number to mbagarwal1@gmail.com. Winner will be the fastest finger first. We now move on to the weekly case study. A 59-year-old woman, osteopenic, on bisphosphonates. History of recurrent urticaria and episodic palpitations with flushing and pruritus, responding to antihistaminics for the preceding 9 months. First seen in 2019 for intertrochanteric fracture of left femur by the orthopedic department. CT scan of the hip showed unexpected lytic lesions in both the femora and the pelvic bones. Hence, pathological fracture was suspected. Whole body PET CT scan revealed lytic areas in the ribs and the sternum, together with compression fracture of L1 and L4 vertebrae. PET scan and other investigations did not reveal any obvious primary visceral malignancy. Serum and the urine protein profile did not show any evidence of monoclonal gammopathy. Intramedullary fixation and open biopsy of the fracture site were done. This shows you the plain X-ray of the left hip joint. And what you see, what has been pointed out by the arrow, is the intertrochanteric fracture of the left femur. And that's the CT scan showing you both the intertrochanteric fracture and the additional lytic area in the left femur. The two arrows here. And this is CT scan showing you multiple lytic areas, both in the femur and in the pelvic bone. And this is the post-op X-ray of the hip joint. Post-op day 5, patient had an episode of hypotension, tachycardia, flushing and pruritus, needing intravenous antihistamine. Patient described this as the same typical allergic reactions that she has been getting during last 9 months. Open biopsy of the fracture site showed large aggregates of spindled and round cells that were positive for CD117. And these were showing metachromatic granules on GIMSA. The further IHC showed them to be CD25 and CD2 positive, and these cells were therefore diagnosed as mast cells. The bone marrow examination was carried out, which showed 25% spindled mast cells. A diagnosis of systemic mastocytosis aggressive variant with osteoporosis leading to pathological fracture, and this osteoporosis being due to systemic mastocytosis was made. KIT mutation study showed D816V mutation in exon 17. Her osteoporosis was treated with calcium, vitamin D, and continuation of bisphosphonates. After 2 weeks, patient was ambulatory and walking with a walker, and after 3 months, she was walking without support. An X-ray showed a stable implant, healed fracture, and no complications. Her aggressive systemic mastocytosis was treated with midostaurin, and she was prescribed epinephrine auto-injector for the episodes of flushing. This is the biopsy from the fracture site showing you the spindled mast cells and the eosinophils. And you can see the clumps of spindled mast cells here. And the GIMSA stain showing metachromatic granules, which are best appreciated in this. And this shows you the X-ray after 30 months, stable. A little bit of review of systemic mastocytosis. It's a rare hematological neoplasm. It's characterized by proliferation of abnormal clonal mast cells in cutaneous and extracutaneous organs. As per WHO, the diagnosis is based on well-defined major minor criteria. And these include pathognomonic dense infiltration of mast cells, which can be detected in the bone marrow, elevated serum tryptase level more than 20, abnormal mast cells expressing CD25, and identification of the characteristic mutation KIT D816V in almost 90% of patients. WHO classification subdivides mastocytosis into two groups, the cutaneous form and the systemic form. In the systemic form, there are 5. 2 of them are relatively slow progressive disease, indolent and the smoldering, and 3 of them are rapidly progressive, systemic mastocytosis with associated hematological neoplasm, an aggressive SM to which our patient belongs, and the mast cell leukemia. Most of the patients of systemic mastocytosis carry the somatic point mutation of KIT at codon 816, and the figure varies from 80 to 90%. The symptoms of systemic mastocytosis are listed here, and the size depicts their relative frequency. So the common ones are vomiting, malabsorption, abdominal pain, skin changes, pruritus, diarrhea, urticaria, nausea, and migraine. And in small percentage of patients, there can be myalgia, ascites, fever, chills, anorexia, bony pain, arthralgia, erythema, dizziness, asthma. As far as the osteoporotic fractures are concerned, vertebrae are the commonest site. And after them, there is femur, followed by humerus, then pelvis, the tibia, and the ribs. The management of systemic mastocytosis, if it's cutaneous, indolent, or systemic but without progression, then you manage the osteoporosis, continue other symptomatic management, and monitor for disease to progress. If it is rapidly progressive, systemic or aggressive disease, then besides bone density management and the symptomatic management, you have to give specific treatment. And if it's KIT positive, it's midostaurin. If it's KIT negative, dasatinib or imatinib could be helpful. If cytoreduction is needed, you have hydroxycarbamide, that is hydroxyurea. Interferon can be used. And if the tumor is CD30 positive, you can use brentuximab. Mast cell leukemia is treated with midostaurin, high-dose cytosine arabinoside, with or without fludarabine and cladribine can be used, and stem cell transplant if the patient is eligible for the same. That brings us to inauguration of our today's webinar by our special chief guest, Dr. Pravas Mishra. It's my pleasure to introduce my friend, Dr. Pravas Mishra. At present, he is director of the Hemato-Oncology and Bone Marrow Transplant at Max Super Specialty Hospital, Delhi. Earlier, he was in the Department of Hematology, AIIMS, Delhi, for almost a decade. He is currently the chair of the ICMR Committee on Acute Lymphoblastic Leukemia. He did observership in City of Hope, Hammersmith, King's College, and Westmead Hospital in USA, UK, and Australia, respectively. He also worked for 2 years in a rural hospital near Paitan in Maharashtra. He has several publications in both national and international journals. He has several awards for the best paper presentation in international conferences. He did his DM in clinical hematology from AIIMS, New Delhi. And earlier, he did MD in internal medicine and MBBS from MGIMS Sevagram, Wardha, Maharashtra. I request Dr. Pravas Mishra to inaugurate our webinar and give some words of wisdom. Thank you.
Good afternoon. At the outset, I must thank Professor M.B. Agarwal for having given me this opportunity to talk to my young colleagues. My journey into hematology started during my senior residency at the St. Stephen's Hospital, Tisajari, that is in New Delhi. Like many freshly minted internists at the time, our prime aim for those of us who wanted to pursue a subspecialty after MD medicine was to get into one of the more glamorous subjects like cardiology or gastroenterology. However, while I was at Stephens, I realized that unlike the other branches, there was very little understanding about patients who came to us with hematological problems. Anemia was never, evaluated adequately. Coagulation parameters were never understood. And unlike other branches, most of the patients with hematological problems, which were not nutritional in nature, ended up being referred to higher centers like All India Institute of Medical Sciences. So I decided, why not take up this branch? And at that point in AIMS, there was a choice between a non-academic senior residency, either in hematology or in medical oncology. So which one to take? I had not had the good fortune to have attended any of Professor Agarwal's conferences at that point of time, and I had to take a very considered decision on my own. Now, you see, the way I had been taught clinical medicine at the time was that the art of medicine involved many aspects. The art of taking a good history, a thorough examination of the patient, making a differential diagnosis, planning appropriate investigations as per your differential diagnosis, interpreting the results of those investigations, planning the treatment, counseling, follow-up, and so on. I felt at the time, and still do, that hematology offered all this and much more. Once I joined hematology, I learned that a hematologist is a clinician, a pathologist, an intensivist, a radiologist, and an infectious disease specialist all rolled into one. After all, in addition to all the skills that I mentioned earlier, which other branch of medicine where you do a biopsy in the morning and then look at the peripheral smear and the slides by evening, come to a diagnosis and start treatment on your own? So thereafter, once you start to treat patients with leukemia, marrow failures, and take up patients for a blood or marrow transplant, you realize that you have to be on your toes and remain alert at all times for electrolyte disturbances, infectious complications, drug side effects, and so on. In most centers, I would say that your knowledge of infections in immunocompromised individuals would be second to none. You have to be an excellent clinical pharmacologist, a great infectious disease specialist, a pathologist, and also all of this, foremost a clinician as well. Now, as a hematologist, you will have ample opportunity to improve your communication and people management skills, wherein you need to explain difficult concepts, not just to the patients, but also to colleagues in other departments. You will have the opportunity to interact with a wide range and variety of colleagues, nurses, paramedical staff, radiologists, microbiologists, pathologists, and all in the space of a single working day. Now, it is in addition to all of these, you have to have a good understanding of genetics and molecular pathology as well. You will be expected to have a thorough understanding of the basic laboratory concepts in hemolytic anemia and in the coagulation lab, including their pitfalls, so that you don't make blunders. Hematology, you see, is an information-rich subject, and there are times when I feel that there could be an information overload. If you're not careful, one can get sidetracked very easily and go down a rabbit hole of investigation after investigation, and your skills as a clinician and an evaluator of complex data would be tested to the maximum. The same set of investigations could mean several different things. Hematology has been and remains at the forefront of cutting-edge medicine. From sickle cell anemia to targeted therapies to cellular therapies and truly personalized medicine based upon genetic data, this branch of medicine, that is hematology, has been a pioneer in more ways than one. Today, you will be listening to Dr. Kunal Sehgal, who will be taking you through issues pertaining to the platelet count, and you will understand how important it is to listen to your patient and to examine your patient in a competent manner to be able to analyze a laboratory report. With that, I end this introduction. For those of you who are contemplating a career in this branch of medicine, I do hope my little speech has given a flavor of what hematology has to offer. Thank you and namaskar.
Well, thank you so much, Dr. Prabhash Mishra, for those golden words. Very inspiring. I'm grateful to you for sparing your time. We are extremely fortunate to have Dr. Kunal Sehgal as our guest speaker at more than one occasions. He's always obliged and taught our students and seniors alike during last 2.5 years through these webinars. He doesn't require an introduction. You all know him extremely well, but to complete the formalities, he's consultant hematopathologist and flow cytometrist, director, Sehgal Path Lab, standalone hematopathology and flow cytometry lab in Mumbai. He did his MD pathology with gold medal from PGI Chandigarh. He did his hematopathology training and fellowship at the prestigious Tata Memorial Hospital, Mumbai. He did UICC, ICC, RETT fellowship from Johns Hopkins. He was ex-consultant hematologist at PD Hinduja Hospital, where he worked from 2011 to 15. He has 10 years of experience in hematopathology. He has special interest in hemato-oncology diagnostics with focus on bone marrow and flow cytometry. Today he's going to speak to us on approach to thrombocytopenia and platelet count, practical tips and troubleshooters. And over to our speaker for the day.
A very good morning to everyone. Thank you, Agawat sir, for this kind introduction and opportunity to speak to this esteemed audience today. While I share my presentation at the outset, I'd like to thank all the attendees joined today, also all the discussants, and apologies to all the experienced people because my talk is going to be extremely basics. I am going to be back to very basic cases of platelet count. Divided the talk into two aspects. The first is approach to thrombocytopenia, where we'll get a theoretical discussion, followed by platelet count, where I will discuss mainly on the principles of platelet count, the basics of platelet histograms, and potentially share my experiences more on the laboratory and the pathology side, and not too many complicated cases as such, but I hope that I can bridge the gap between the clinician and the laboratory, because I know thrombocytopenia or accurate platelet count is always a bane of contention between the clinician and the pathologist, always. So without wasting further time, before I go to thrombocytopenia approach, let's look at a very brief aspect of normal thrombopoiesis. It is the liver which constitutively secretes thrombopoietin or TPO. And this TPO binds and is catabolized by the CMPL receptors, which are present on both the platelets and the megakaryocytes. So the actual thrombopoietin levels in blood are directly proportional to the mass of receptors. And this word mass is important because the platelet count and the megakaryocyte number varies individual to individual. So the total mass of MPL receptors in the marrow and the platelets in the peripheral blood will decide the thrombopoietin levels in the blood. Typically, if there are adequate or more platelets, all the TPO in the peripheral blood will try and be bound to the platelets, to the CMPL receptors. So there is less thrombopoietin available in the marrow for the megakaryocytes. So the thrombopoiesis is decreased, which is logical. However, in case, for example, in peripheral destruction of platelets, there is a less platelet pool of or a platelet mass of CMPL receptors in the peripheral blood, which means more thrombopoietin is available to stimulate the megakaryocytes in the marrow, which means increased thrombopoiesis, which is what we see in conditions like immune thrombocytopenia, thrombocytopenia purpura. While this was constitutive secretion of thrombopoietin by the liver, we also know we have conditions of reactive thrombocytosis. For example, in inflammation, where there is release of IL-6, which causes increase in thrombopoietin production. And we very well know on the clinical side that we use thrombopoietin analogs for treatment of thrombocytopenia like romiplastin and related drugs. Also, for example, in cases of liver cirrhosis or liver dysfunction, you almost always have a mild to moderate degree of thrombocytopenia, typically because of decreased thrombopoietin production. So this is a brief on the physiology of how thrombopoietin and platelet function, the platelet count is regulated in the body. Again, the other important thing to remember in practice is the normal units of platelet count. And for example, this is a normal 25-year-old male. This had platelet count of 205,000. And what I wanted to highlight is the normal platelet count is 150,000 to 450,000. But the way the units are written or the way they are described or spoken about, like I spoke, it's 150,000 per microliter or 150 to 10 to 3 or 150 into 10⁹ per liter, previously it was known as per cubic millimeter, they are typically the same. But it is important because platelet reports are often given verbally on messages, not to make a mistake on the unit. So I just put out a slide which says, pick out the pair with wrong units. And I'm just going to read it out. So 55 into 10⁻³ per microliter is the same as 55,000 per microliter. 1.25 lakhs is the same as 125 into 10⁻³. 25 into 10⁹ per liter is the same as 25,000. The difference between liter to microliter should be 10:6. So here from 10:9 it should have gone to 10:3. So this is the wrong pair. It should have been 1,35,000 or 135 to 10:3. The reason of highlighting something very basic here is not to make a mistake in the units while reading, interpreting, or sharing it with your clinical team. So from there, we move to approach on to thrombocytopenia, and this very beautiful article by Robert Stacey is what you will be using as a reference for the next few slides. This is freely available through the ASH Education website. So there he highlights the common causes of thrombocytopenia. So if you briefly state them, first and the most important is pseudothrombocytopenia. So you should rule out platelet clumps, and as we'll be discussing in the cases ahead. Then, is it destruction of platelets? Is it immune or non-immune? Is it the decreased production of platelets? Which means this decreased production could be a primary marrow disorder like a marrow hypoplasia or a marrow suppression, or is it secondary due to infiltration in the marrow, metastasis, or some tumor deposits, or a lymphoma infiltration or myeloma infiltration happening in the marrow. Dilutional thrombocytopenia, and then you have increased sequestration, like an example would be a hypersplenism. So these are the broad causes of thrombocytopenia if you look at the pathophysiological aspects of thrombocytopenia. However, if you were to look from a clinician's perspective, you could also divide them from a clinical scenario, whether this is an outpatient, stable, or severe thrombocytopenia in an outpatient system, and inpatient would be slightly different. So you broadly read out in outpatient, you could have the common ones would be the immune thrombocytopenia purpura or the drug immune, then the infections. Why this is the European American article, you would not come across in this table the common infections which we see in practice, like a dengue viral fever or something like malaria. The various viral fevers which we see in our country, which is extremely common cause of infected thrombocytopenia. And obviously you have the other viruses like HIV, hepatitis, CMV, and so on. Connective tissue disorders, autoimmune disorders, vaccinations, a lot of COVID vaccinations we know associated thrombocytopenia in the last 2 to 3 years. And then obviously you have congenital causes, marrow failures like low-grade MDS or high-grade MDS, and then some rare variable immunodeficiencies. Now, if this thrombocytopenia is in an inpatient, for example, commonly in ICU, you would consider sepsis, infections, DIC, TTP, HUS, is the patient having a liver disease, heparin-induced thrombocytopenia, macrophage activation syndrome, bone marrow disorders, and so on. For cardiac patients, cardiology units, heparin-induced thrombocytopenia is common, cardiac bypass. Do not forget drugs, especially GP2B3A inhibitors, and again, dilutional thrombocytopenia, other drug-induced. Pregnancy is a very specific area which I'll discuss in the next few slides. So both the pathophysiological aspects of thrombocytopenia and the clinical scenario is important. And the best way to approach this is the history. Is the patient bleeding? Where is the bleed? What is the type of the bleed? Skin, mucosal? Is it menorrhagia? Is it a massive GI bleed? Is it an intracranial bleed? All have different indications, different causes, and different things which one would think. Is this thrombocytopenia documented as acute or chronic? Is it isolated or there are associated symptoms? Example, fever. Are there any bony pains? Is there any constitutional symptoms? At what age did the thrombocytopenia start? Is there any drug history? Family history in congenital thrombocytopenia is important. Is there heparin exposure? We mentioned about it. What are the basic metabolic profile of the liver and renal function? Is there a liver disease? Are there any risk factors for you to associate with HIV or HCV infections, basically again with the liver function or sexual history of this patient? So when you see thrombocytopenia in practice, the most important test is first to see and examine the peripheral blood smear, which we'll discuss in detail in the case studies if you see. Rule out platelet clumping and rule out artifactual thrombocytopenia. Unfortunately, we keep seeing bone marrows once every 3 to 6 months. For a case of thrombocytopenia, is actually only a pseudothrombocytopenia, and unfortunately, marrow could have been avoided. If it's a true thrombocytopenia, the approach would be on the peripheral smear to look at platelet morphology like giant platelets, to look at the RBCs like cystocytes. You start thinking of microangiopathic hemolytic anemia, and the workup will be in a different direction. If you see spirocytes, RBC agglutination, clumping, you will look at direct Coombs test. You would think of Evans syndrome in a case of anemia with thrombocytopenia. In your considerations will be different. If you see WBC abnormality, now this could range from a reactive lymphocytosis, you could have a neutrophilia infection, toxic granulation, etc. Then you're typically thinking of either sepsis, Y infections, bacterial infections. Your gamut of testing would become different in your approach to thrombocytopenia. If you're seeing abnormal blast, you're seeing atypical or abnormal lymphoid cells in the lymphoma, you're seeing abnormalities associated with MDS, you're seeing a leukocytoblastic picture, you're potentially thinking of a primary bone marrow disorder, and hence the approach will go towards the bone marrow. In case there are no associated abnormalities in the RBCs or WBCs, and then you're looking at isolated thrombocytopenia, you would definitely require all the clinical details which we just discussed. And then you would consider other causes like immune thrombocytopenia, drug-induced variant, things like HIV, HCV, H. pylori, and so on. So this is a combination of a lab approach, peripheral smear, look at other abnormalities, clinical history, and then approach the thrombocytopenia. As pregnancy is a very specific cause, you can, in pregnant patients or pregnant ladies, you can have pregnancy-specific causes or non-pregnancy specific causes. Amongst pregnancy-specific causes, the most common is gestational thrombocytopenia, accounting for more than 80% of the cases. Preeclampsia, health syndrome are also very important documented cases. This typically happen later in the second, third trimester in pregnancy. You need to look at, in health syndrome, for example, the elevated liver enzymes, look at the blood pressure, and then there is acute fatty liver of pregnancy. In the non-pregnancy specific causes, your approach would be very similar to a non-pregnant patient. The causes would also be similar. One needs to document the history of thrombocytopenia prior to the pregnancy, whether the thrombocytopenia is already there. Obviously, rule out pseudothrombocytopenia. Almost always that becomes a must. So, with this very brief approach to the clinical approach to thrombocytopenia, I'll move predominantly into the lab side of things and share my personal experiences of how we tackle platelet counting problems, especially with the focus on the histograms and the CBC analysis results. So before we go there, it is important to know what is the current gold standard. So I'll read out the 4 common things, and you could keep this in your mind or think which one you would think is the current gold standard. Is it the manual phase contrast microscopic method using the NUBA? Is it the impedance-based optical platelet counting? Is it the optical platelet counting method in the current day analyzers? Or is it flow cytometric-based RBC platelet ratio? It is important to go to the historical perspective of platelet counts. And 1882 was when platelets were recognized as distinct corpuscles. Newbar chamber became the gold standard, the manual phase contrast microscopy. Right from 1988, it was made the gold standard, but it was discovered in 1953 for platelet counting. Then from the 60s, 70s, and 80s, we had the advent of semi-automatic and fully automatic analyzers. Impedance counter, impedance principle, which is still used in the most important principle in some counters. Then came the optical platelet count in 1985. Early 90s is when we had antibodies to platelets like 41 and 61. And it is only in 2001 that the flow cytometry RBC platelet ratio was documented as a new international reference method. And when we say and I'll discuss this in the next few slides. So manual platelet count. Now, this has 2 connotations, which is important. Theoretically and traditionally, manual platelet count is always done on the Newbar chamber. But today, we will get in the lab a request for manual platelet count. And typically, most labs who do the manual platelet count is a peripheral smear platelet estimate. And I want to highlight these are 2 totally different things. As far as the Newbar chamber count is concerned, we know this is laborious, time-intensive, subjective, and a very high inter-observer CV of 10 to 25%. Especially at very low platelets or very high platelets, this is extremely cumbersome and can be very difficult to have very reproducible results. Now, this is the international flow reference method. What do? They use an antibody CD4161, which binds to the platelets, separate them from the RBC based on the size. You take the ratio of platelet upon RBCs, platelet events upon RBC events, multiply that by the RBC count from the analyzer. So this is not a method to measure platelet count day to day in your instrument. This is a method which is used for validation by the companies or verification by the users. This is an article which we published in 2010, very close to my heart. This was on the International Flow Reference Method. It was my first author international publication, where we compared two different cell counters along with the Rhea matrix method, and we did the flow reference method. The same thing, the platelet events bound by the 4161, and then there was a RBC events on the flow. Multiply that by the analyzer. This is supposed to be the most accurate way of measuring platelets, and this is what all companies before they come to the market would have compared platelet count from their machine with the flow cytometric reference method. Now, the peripheral smear platelet count is really not a count, and I would personally say I label it as a peripheral smear platelet check or a platelet estimate at the most. The reason being, this is highly subjective. We all know the problems of platelet clumps, platelet saturation, and I'll show you cases where there's poor smearing, and we know this is highly subjective. It is important while doing a peripheral smear estimate to identify the right area where to see the platelets. We do not go deep into the tail. We do not go deep on the edge of the tail or deep into the body. We want to go into the area. The tail has all these clumped RBCs together, almost clumped with these empty spaces. You will not get an accurate count. This is an area where there is overlap of RBCs, too thick an area to count. So you go into an area where RBCs are individually separated from each other. In an ideal scenario, if I was to give you an image and say this is a 100 oil objective image and this is the more representative image, under a microscope, which is the current generation with a field of view of 21 mm, one would count the platelets, and this is to save time. There are around 17 platelets on this field, and the multiplication factor which we personally use in our lab is a multiplication factor of 10,000. So if the average count in 10 fields was around 17 platelets, we would use the multiplication factor of 10,000 and give a count of 1,70,000. The reason I mentioned field of view is very important. In the older microscopes, your field of view is 18 mm. Nowadays, you have microscopes with digital screens, you have camera-based screens. Your area will be very different. So if I was to see only a small square over here, instead of counting 17 platelets, I would have counted 12 platelets. If I was to see a bigger rectangle over here, I would have counted more platelets. So the field of vision becomes important. And this is where the subjectivity of the multiplication factor comes in. There are books which refer to 15,000. There are older multiplication factors use 20,000. But our personal experience says 10,000 based on the current day microscopes, and I would suggest that one would use their combination of the instrument microscope and come to their own factor. But in most times, this is very helpful. Just to re-highlight, in low platelets, you might need to count more fields, 10 to 20 fields. For example, if you counted 10 fields and got a total of 45 platelets, the average platelet per field would have been 4.5. You multiply and your platelet estimate would be approximately 45,000. Check this with the analyzer count. If the analyzer is giving a count of 50,000, 40,000, you're almost the same. Do not worry. But if you feel your analyzer count is 10,000 or it is 1 lakh, that's a gross difference. You need to look at why that is happening. At very low platelet counts, count more fields. So, 20 fields, you got only 40 platelets. Your average platelet for field is 2. An approximate platelet count would be approximately 20,000, a platelet estimate. And at these counts, we know the analyzer may give 15,000, 25,000, you may not match. And that is where the subjectivity comes in. At such low counts, it will be very, very difficult to estimate an accurate thing on a peripheral smear. Obviously, then we have problems because of platelet clumps or saturatism. There is no way, no method where one can then achieve an accurate platelet count. Important to identify what is the giant platelet. This is an image of a small activated lymphocyte. This is a giant platelet next to a RBC. So a giant platelet is almost the size of a small RBC, again highlighted over here. This is a slightly smaller platelet, so one needs to go back and see and define this is typically a small RBC size platelet is what we call as a giant platelet. Beware of artifacts. This is a slide with a lot of stain deposits. Practically, which is a stain deposit, which is a platelet, if there are any, is impossible. And you cannot do a peripheral smear estimate on such a overstained deposit slide or an extremely light stain slide. So be very careful when you have staining artifacts before reporting platelet. This obviously I'm sure you'll recognize is pools of platelet clumps on the tail of the smear. So while I said document platelets at the area between the tail and the body, but a low power evaluation of a tail in every peripheral smear is a must, because this is where small and large clumps will be found. So do it both on 10 and 20, 40, 100, whatever you are used to and experienced with. Please identify platelet clumps, because that completely changes the scenario from a clinical perspective. Now, while this was a case of EDTA-induced pseudothrombocytopenia, which is typically pools of platelet clumps, these are large clumps. One needs to recognize these are very small clumps in this image, 3 to 4. Many times we see a report saying small clumps seen, please send sample in EDTA and citrate. This is not typically a feature seen in EDTA-induced thrombocytopenia. These are very small clumps. Also, this is a case where we had a stored sample, transported stored sample, kept in the fridge, run the next day, showing low platelet count. And if you see this, there are platelet clumping seen over here. There is degeneration of the WBCs. You can typically see artifacts due to degeneration of cells. And this is also one of the reasons of pseudothrombocytopenia. So one needs to be aware of the sample age before you make the smear. And if you were to just keep your normal sample in the fridge for a day or two and reevaluate the smears, you might see artifacts like this. So moving on to automated CBC analyzers and their principles of measurement. The traditional principle always has been the impedance principle, and the latest technology, which often many analyzers have, is optical, and now we also have the flow-based counters. So impedance principle, very simply, we have cells. The counter does not know what cells they are, RBCs or platelets. It just moves as particles between two electrodes where the resistance to signal is measured. And we know if the particle is of a smaller size, there is a smaller pulse generated, a bigger size, a bigger pulse is generated. So typically we collect all the pulses, different size, different number of counts on the y-axis, size on the x-axis. The size is in femtoliters. So whether it is platelet, RBCs or WBCs, on your basic CBC histograms, the x-axis is the femtoliter, that is the volume of the cell. On the y-axis, you have the relative cell count. So in a typical platelet histogram, we have different sizes of platelets. As you see over here in the pictogram over here, that you have different sizes of platelets. Depending on how many small platelets, how many medium platelets, the histogram will be formed. And then this is the trough between the RBC curve and the platelet curve. Now, what is important to highlight, the actual histogram is actually the same, the platelet and the RBC. For our ease of use, the cell analyzers will divide the left part of this histogram and give us the platelet histogram, and the right part of this histogram as the RBC histogram. Here, as I said, the cell counter does not differentiate between platelets and RBCs. It differentiates cell volume. So typically the platelets are measured between 2 to 30 femtoliters. Typically the RBCs are measured between 25 to 250 femtoliters. This may slightly vary between different analyzers, different histograms. This is from a traditional 3-part histogram, and you may see different looks and feels of the histogram in different analyzers. This is just few examples from few machines. This is on the Sysmex analyzer. This is a normal platelet histogram. Starts at the baseline, ends at the baseline, and then the RBC curve starts. Here, the platelet histogram starts at the baseline. There's a zigzag pattern, does not end the baseline, and we discuss why this happens, and then the RBC curve starts. Now, this is on a Coulter machine. You divide the RBC and platelet, though they are two different histograms. As I said, the size of the platelet is small, which is there on the left part, not shown here. The size of the RBCs are large on the right side, not shown here. They split it into two histograms. And then this is also the WBC histogram, which you also see in 3-part analyzers. On the Beckman-Coulter machines, they have a very interesting and good technology where they give two curves. The green one is the basic normal curve, and the black one is the curve fitting technology, where it smoothens the curve to give a curve corrected platelet count. So going back to histograms is very important, and this is what I said, you need to go back to the basics, because as pathologists, laboratorians, even clinicians who see a lot of histograms reports, this is very important to identify problems in the histograms and to understand the basics. Platelet count starts between the fixed threshold or the 2 femtoliter margin over here. Below this is all interference which might come from dust, bacteria or poor fluidics or poor electronic noise in the system. This threshold on the right side, which is called the upper platelet or the lower RBC threshold, is also called as the moving threshold. Now, The lower threshold in some terminology may be called as lower discriminator, or because it is the PL or the platelet low threshold. The upper discriminator for platelets is also called as the platelet upper. But remember, this is also the lower discriminator for RBCs. So it may be called the RL. So these terminologies may be slightly different in your analyzer. What is important when you look at the platelet histogram, typically the histogram starts at the baseline, moves up. Typically it's a little left skewed, and there is another threshold at 12 femtoliters, and I'll come to that in the platelet indices. Most majority platelets are lying in the left skewed region, and then there are fewer bigger size platelets, and the histogram curves down to end between somewhere between 20 to 30, and this is how a normal histogram looks like. Now you can have different problems in your platelet histogram, and I'll show you through these case images. So as I said, normal histogram would have started here at the baseline. Here it does not start at the baseline. That means there is interference coming below 2 femtoliters, and we know platelet size is typically bigger than this. So what are the things which will interfere? Will be bacteria, will be contamination in your fluids, will be electronic noise and disturbances coming from your machine. If the right side part of the histogram, so the gray line is your reference where it should have ended the baseline, does not end the baseline, which means there are larger particles coming into this area. Now, these larger particles can come from two sides. From the left-hand side, which is the platelets, or the right-hand side, which is the RBCs. From the left-hand side, it could be the giant platelets, or platelet clumps, or platelet aggregates. From the right-hand side feature would be the RBCs coming into the platelets, which could be either RBC fragments, or there is cystocytes, or there is severe microcytic hypochromic picture. So the machine cannot differentiate between small RBCs and platelets. A rare scenario, but not too uncommon. One may rarely see this. Two peaks in RBCs, we see something similar in transfusion. You could see this in platelet transfusion. You could see this recovery from chemotherapy, and multiple peaks can also be seen due to platelet aggregation. So simply looking at these histograms, identifying where the problem lies right on your cell counter, and training your technologist will also aid to identify potential causes for thrombocytopenia. A very brief idea about the platelet indices, often not given too much value in report. They have clinical importance in a case-to-case scenario, while I'm not going to focus on them today. But it is important to understand mean platelet volume, just like the MCV of RBCs, is nothing but platelet crit divided by the platelet count. So in MCV, we have hematocrit divided by the RBC count. In MPV, we have the platelet crit divided by the platelet count. Approximately the value between 9 to 12 is what is considered as normal. And you have slight age-specific ranges at times, which will have instrument to instrument. Anything more than 11 to 12 as an MPV typically identifies that as giant platelets. Now, there is also a popular parameter called as platelet large cell ratio. And as I said, between the fixed threshold of 2 and the moving threshold of 20 to 30, there is also often a threshold of 12 femtoliters. This is there because most platelets, most platelets are on the left-hand side. So as I said, the platelet curve is skewed. However, if you have a higher number of platelets above 12 femtoliters, so this area is what is used for measurement of platelet large cell ratio. It just tells you there's a higher number of giant platelets or larger platelets more than 12 femtoliters in volume. Just like we have RDW, red cell distribution width, which tells us about inozocytosis of RBCs, one can use PDW, which is platelet distribution width. It is measured at 20% of the height of the platelet curve. Often, these are very useful in thrombocytopenia patients. However, one would agree and one would see that many times when there is a giant platelet clumps, or there is an abnormal platelet histogram, the values of MPV, PLCR, and PDW get voted out because the machine cannot accurately measure them. And that is where we go back to the peripheral smear morphology, and that's where morphology rules the roost. Now, as I said, the challenge between impedance count for a counter is it does not know whether it is platelet or RBC. It only knows sizes. And it is putting a threshold where it feels there is the trough between the RBC curve and the platelet curve. Sometimes this trough is not clear. So when there are giant platelets, when there are RBC fragments, or there are platelet aggregates, there is an overlap area where the machine cannot recognize. Now, this is the challenging area where it will start giving us wrong platelet counts and impact our clinical scenario. This is where the technology of optical platelet comes in. In the optical platelet technology, in this scattergram, which is a 2-parameter scattergram, just to highlight, on the left side, on the y-axis is the forward scatter, which is representative of indirectly proportional to the size, directly proportional to the size or volume of the cell. So here, these smaller size cells on the lower part of the FSC axis are the platelets, and the larger ones over here in blue and purple red are your RBCs. So what will happen is, these are normal size RBCs, smaller RBCs are lying here. Now you would say giant platelets would lie here, and again the same problem would occur. However, here we also have an x-axis, which is called as SFL in this instrument, or site fluorescence. So typically we put a dye which binds to any RNA containing cell. In the RBCs, these purple and red are RNA containing reticulocytes. And here in the light green dots are your RNA containing giant platelets, which are also called as reticulated platelets. And amongst this, based on a position algorithm, is measured the IPF or immature platelet fraction. So what typically happens is, because the early immature platelets contain RNA, they bind to the dye. So the giant platelets move into this direction and the small RBCs move into this direction. So this overlap area, which was seen in the impedance count, gets separated, smaller RBCs on the x-axis here and the giant platelets on this axis. So in conditions where there is a lot of anisocytosis in platelets, where there is thrombocytopenia with a lot of giant platelets, typically in this rhythm we see in dengue-induced thrombocytopenia due to peripheral destruction. This is where in low counts, sometimes the optical platelet count will give you a far better count, and you can easily recognize that from the histogram. So here, this is an histogram where in a scenario where if you had severe microcytosis, which was interfering with your platelet count, here if you see the density of small RBCs in the x-axis is very high, and there is not much of the green giant platelet dot, which is almost normal. However, in this scenario, there was no microcytosis. This is all typically giant platelets. And compared to the left plot, you see on the right-hand side plot, there is a large number of giant platelets, very small amount of microcytic RBCs. These are easily separated by the optical platelet counting method. In a given clinical scenario, for example, not uncommon, this is a lady from East Indian origin from Bengal. She was a blood donor, was documented outside to have thrombocytopenia. So one, you are doing a good job of donating blood to your relative, but you got labeled as abnormal. But we know based on the history that these patients, not patients actually, are possibly having the normal condition of macro thrombocytes, where they have a slightly lower count compared to the 1 lakh threshold, but their platelet size is very high. In this scenario, the optical platelet count is extremely useful. The count was 1,62,000, definitely within the normal range, and was potentially could easily donate blood. So while I'm discussing optical platelet count, I know IPF is a very popular parameter. Immature platelet fraction, it's been used for the last many years now, popular amongst both clinicians and pathologists. Would like to highlight its uses and caveats. One, normal range of IPF is instrument specific. Within the same company, it is analyzer and model specific. So if you see, this is the range we had at my time of work at Hinduja on the XC2100 series of Sysmex, 0.7 to 4.7. Whereas on the newer model, it was 0.7 to 6.7. There was a change in dye. And that's why if you see the normal range literature would vary across instruments. So one needs to know this, look at the clinical scenario, look at the report and their reference range. Very basic pathogenesis of low platelet count. If there's increased destruction or usage, there is more stimulation for giant platelets to come out. And a high IPF, for example, in ITP, suggests an active bone marrow regenerating bone marrow. A decreased production. So consider an aplastic anemia, a marrow failure post-chemotherapy. There is normal to low IPF. It suggests a depressed marrow function. A very useful parameter in bone marrow transplant or bone marrow regeneration is that IPF is one of the first indicators, or it starts increasing in cases of bone marrow regeneration. Important to identify, has this IPF increased? Because typically IPF is not best used as 1 point value. It is to be used as a trend analysis system. So one needs to understand at different levels of IPF, what is the CV. So at low levels of IPF, when we ran our samples, so this is a 1,93,000 count, the IPF of 3.5 is normal. The CV was as high as 10%. For a platelet count lower 29, the IPF was 11 with a CV of 10%. At a similar platelet of 26,000, IPF is 16, the CV was 7.9%. The CVs will change based on your IPF value, yes. But you need to understand, and broadly we thought, we came to a conclusion up to 10% is an inherent CV or variation if you run the same sample multiple times. So a jump from 10 to 11 or a 10 to 9 IPF may practically not have a meaning, but a jump from 8 to 10 becomes 20% and then definitely becomes significant. In our previous instrument, we found stability only of 6 hours after collection. In the current day analyzers which we use, we have a stability of almost 24 hours. This is important based on which analyzer you're using. So clinically becomes very, very relevant. And we did this by running our samples multiple times and seeing whether it was more than the defined CV or not. And yes, on the previous instrument used on particular dye, this became unstable. So, based on reticulated content, we know that's a live cell and it will on storage lose its importance. So caveats, and this is very important, and I'll highlight this with an example of 2 different companies with 2 different IPF principles, 2 different IPF algorithms, similar platelet counts in this range. Both company machines give similar count. IPF was 1.7, 0.8, in another case 4.9, 2.3, 12.5 and 5. Normal ranges are different. There are different staining dyes, there are different positional algorithms, different normal ranges. Please look at the impact of recalibration and preventive maintenance. There are no universal controls present across analyzers. So hence, it is very platform specific. So this is a message to the clinicians: know the report, know the range, and then utilize it from a clinical perspective. The another caveat which I would like to highlight over here is it's a positional algorithm. Means it is based on an algorithm and becomes very difficult when the platelet counts are very low, and that is very useful. However, when it is very low, less than 10,000 or 5,000, you may get a very high value of 20%, 30%, 42%, for example. It indicates there is giant platelets and there is a mallow recovery, but that actual value of 20, 30 or 40 may not be highly reproducible. This is because the number of platelet events counted are too low for accurate measurement and the CV becomes very high. This is especially when the platelet counts are dipping below 10,000. So you need to use the absolute value with a pinch of salt. Again, just like we evaluate platelet histograms, the IPF histograms also need to be evaluated by pathologists in the laboratory before releasing it. And I'll show that to you. This is a low platelet count of 1,05,000. The IPF was 6.3%. This is my normal reference histogram. This is how my platelets, and these are the green ones, is where the IPF, as I said, positional algorithm. This is where my IPF will be measured. This is where my IPF is measured. This looks perfect shape. The shape is normal. It looks reliable. This, I don't need to even look compared to the reference. There is data here. The shape is not there. Platelet count is low. There are random dots not forming this typical, C-shaped shape over here. This I know is an unreliable data, should not be reported. And if I run this sample multiple times, my IPF will vary drastically. Now, this is another case. I'll show you the platelet count of 22,000. There were flags given your platelet abnormal distribution, maybe platelet clumps, platelet abnormal scattergram. Even the IPF scattergram, if you see, is completely abnormal. This slide was full of clumps. Okay, just like the platelet count is not reliable in a patient with platelet clumps, similarly, the IPF is not reliable. So not only using the platelet histogram, but also using the IPF scattergram becomes very important while reporting platelets. And these are small caveats which I would like you to keep in mind. Now, moving to short case studies, this is just sharing practical issues which we face in our day-to-day practice in the lab, and how do I circumvent this on a personal basis or what we do in our lab. Some of these cases are extremely basic and more focused for students and pathologists. Platelet count of 1,05,000 and we are seeing multiple small clumps. Now, what does one do? And this is a typical question which I asked. Do you report the platelet count without any comment? That obviously would be wrong. You ask for a repeat sample, a common practice, but you ask and say, I cannot measure platelet count, do not give any platelet value. Then you will get a request, please do manual platelet count by Newbar chamber. Obviously, we know platelet clumps, any method, Newbar optical flow will not give an accurate count. The answer, none of the above. What we should do is, because when the platelet analyzer is counted as 1,05,000, you and I have the confidence that at least it is 1 lakh and above. Because the clumps will not lead you to accurate count. You cannot measure the actual count. So one could at least tell the clinician that while the machine is reporting 1,05,000, there are clumps and the actual count, accurate count cannot be estimated, and it may be more than the above count. Now, every time if you ask the clinician to repeat, And imagine the patient is due for a very basic surgery. For the clinician or the surgeon, the adequate count is more than 1 lakh. He will say, I trust my laboratory. I know there are clumps. The platelet counts are adequate. I can go ahead with my procedure. Yes, ideal to repeat, but sometimes it may not always be possible in an emergency. The next scenario, here you have completely normal platelet counts and you see similar clumps. What do you do? Again, some people might say, how does it matter when the platelet counts are normal? You're not dealing with thrombocytopenia. It does matter because you don't know whether this patient is coming to your lab after visiting 4 other labs. A common scenario in private practice, somewhere was reported as 6 lakh platelet count, and today in your sample you're seeing clumps. Or there's a sudden drop from previous day platelet count, or this is a case of MPM. So it is very important, even with normal counts, if you see significant clumps, you mention that in your peripheral report. Now the biggest challenge is at 35,000 you start seeing small platelet clumps. This is where you are seeing only occasional small platelet clump. This is where knowing the clinical scenario history is very important. There is no way one can give a very accurate count. If there are multiple clumps, the only answer I have is to repeat a sample for an accurate platelet count. A very occasional small clump of 3 to 4 platelets, overall it appears low. I would pick up the phone, mention in the report, there's an occasional small clump. Overall, the platelet appear reduced. Definitely requires a repeat evaluation for a more accurate count or a follow-up. Typically, we know, especially in admitted patients, ICU patients, they're going to have 12 hourly or 24 hourly platelets. Look back at the history. Is it a patient on chemotherapy? Is it a patient on follow-up? What are the previous counts? Was it 2 lakhs yesterday and 35,000 today? Then it's a problem. We definitely need a repeat. So this is the way one would approach these kind of clinical scenarios, especially in oncology practice, hospital practice. This is not uncommon. But everywhere, one thing I would like to highlight, peripheral smear remains the most important thing, and that needs to be evaluated for platelet clumps. Now, a scenario where you were asked to see a platelet count thrombocytopenia on the smear, you looked at the peripheral smear, and if you were to count platelets again over here, I would say 1, 2, 3, 4, 5, 6, 7 platelets. If this was your representative field of view at 100x average platelet, you would say okay, approximately 70,000. But there is more on the smear. These are classical schistocytes. This is a classical case of microangiopathic hemolytic anemia. Now, not only are you supposed to release the platelet count, this is a medical emergency. This is where I always recommend the laboratorian pathologist pick up the phone, speak to the clinician, identify what is happening with the patient, share this is a medical emergency. So thrombocytopenia in such a scenario is very important that you document and look at the other findings, look for blast in the WBCs, look for leukoerythroblastic picture, look for RBC changes, look for spirocytes and stuff like that. This is just one of the examples. And obviously a retic count in this case would also be very useful. Now, this is another case study from an instrument which I would like to highlight. For example, here on this Coulter instrument, the platelet count was 2,94,000. If you look at the platelet histogram, bang normal. There is nothing abnormal over here. But the machine is telling me there are platelet clumps. And you'd wonder, why is this machine telling me there are platelet clumps when the platelet histogram is normal, the platelet count is 2,94,000. Now, the important thing to highlight here is the WBC histogram. And this, on the left side of the WBC histogram, is what we call the ghost area. Now, here is an important scenario where normally below 50 femtoliters, that's typically where the lymphocyte site starts. In the WBC channel, the RBCs are live, so they don't interfere. So, and there is normally nothing which is there in the this region of the histogram. So normally this curve would have ended at the baseline and not ended in the middle of this place and gone here. Things which can come over here are platelet aggregates, so they become bigger in size. NRBCs, malarial parasites. So the answer to this question would have been all of the above. All of these can interfere into the ghost area. So the idea to highlight is, in our cell counter, you may have a normal platelet count, you may have a normal platelet histogram. This would have been a normal WBC curve where there is nothing. But if you see a ghost area, okay, one of the things you would look for other than NRBC's platelet, NRBC's malarial parasite would be platelet clumps. Anyways, all three are seen best on a peripheral smear. So that again highlights looking at not only one histogram, the RBC histogram, but all platelet histogram, but also at the WBC histogram. Now, this is another example. 72-year-old gentleman, the hemogram revealed thrombocytopenia of 54,000. Machine gave it as giant platelets. Now, as I'd shown you earlier on the Beckman instrument, there's an interesting principle called of curve fit technology, where in addition to the green curve, it smoothens the green curves, makes the black curve based on an algorithm. Here, if you see that curve correction is absent, the machine is telling you, I don't know how to smoothen this curve. I am not confident about this curve, and hence it gives you some flags based on that curve. This is telling you I may be wrong. Please see the scenario. So this is again that normal curve. If you see the green and the black is curve correction, and then there is an abnormal curve over here. Typically, we saw, this was the slide which I showed you earlier. This is a case of EDT-induced pseudothrombocytopenia. These are pools of large platelet clumps, showed a count of 54,000 on the counter. We asked for a repeat sample in citrate, the count of 235,000. Keep in mind, when asking for a repeat sample in such scenarios, also take a direct smear made from the last drop or the first drop during the point of collection. This is important because sometimes even the citrate sample may show significant clumping and may not be able to give you an accurate count. So a last couple of cases which I'll share with you. This is rare, but again, identifying the importance of the histogram. Here, the platelet count appeared 1,39,000. And sometimes the platelet could have been around 1,60,000. However, on this histogram itself, you can see the moving threshold, the green line over here, has moved to its max. And there is, you cannot objectively define where would this machine have put the this moving threshold, because the machine also cannot make it out. There are too many zigzag curves. This is a completely abnormal histogram and a clear-cut indication for making a peripheral smear. Even if this count was 1,90,000 or 2,30,000, based on this histogram, I would recommend you need to make a smear. Based on this histogram, a smear was made. There were only 1 to 2 platelets for high power field. So even if I counted an average of 2 platelets multiplied by 10,000, my count would have been somewhere between 10 to 20,000 and not 1,39,000. So we were very surprised to what is happening. And this was an ICU sample. I said, there is something which is interfering. Is it the RBCs? MCV was 75.8 because I thought there are fragments, microcytic. Is it a degeneration? Is there something happening? But there was not significant microcytosis. There was some 75.8, but not enough to really cause this kind of a false count. For some reason, we thought, okay, let's do 2 things. We ran the optical platelet count over here. It was not asked at 4. And this was 10,000. So this matched completely. And we were like, why is this 10,000? There's something abnormal. Now we are very sure there's some interference in our platelets coming from the RBCs. We spun the sample. This is the hemolyzed sample due to a difficult collection. ICU sample, difficult veins. We asked for a repeat collection. And now the impedance count was also 11,000, the repeat sample, without any problems. A rare scenario, but only trying to highlight not the hemolysis, very uncommon as an interference. Even if you run hemolyzed sample, it will not give you a false problem. This was due to more artifacts in the sample, but the importance of knowing the histogram even when close to normal platelet counts. Now, this is very clinically relevant both for our physicians and the lab to understand what is the acceptable allowable difference between platelet counts. We have 2 scenarios. First run platelet count was 2 lakhs. Second run platelet count was 1,92,000. In a very good standard analyzer, if you run the same sample back to back, this would be slightly more than what we would expect. But imagine this was some run in the morning and this is run in the evening, or 24-hour difference. Sometimes we have patient asking, my platelet count has dropped, what has happened? But this we know is only a difference of 8,000. In terms of variation, it is only 4%. This is definitely acceptable. But if you ran the platelet count 24,000, first run, same sample, run it immediately again, and the same machine gives it 16,000. Now the absolute difference is again 8,000, which is similar to here. But the absolute difference year and year is very different because in terms of percentage, the difference is 33%. And this may have a huge clinical impact in the scenario. Now, we know this because often 10,000 or 20,000 based on the clinical scenario is the transfusion threshold for platelet transfusion. So this, as pathologists, we should be very well aware. And this is where we need to know how much variation we accept. 2 things to highlight. In a patient who has a suppressed marrow, for example, in aplastic anemia, a bone marrow failure, or a patient post-chemotherapy, where the platelet counts are very small, size is very small, platelet count is low in that 18 to 20,000. You run the same sample, you get pretty good CV. The machine will be pretty good at that range, even at 20 to 30,000. It will give you good variation on the impedance count. However, you take a dengue patient sample with a similar count of 18 to 20,000, where there are a lot of giant platelets. Your impedance count will have trouble in giving you accurate count. The CV for same platelet count in a chemo patient of 20,000 and a dengue patient of 20,000 for the same analyzer will be very different. This is very important to recognize for both clinicians and pathologists. Why? Also because this is something which we need to study in our lab, in our machine. We rely on the CV given by the quality control samples and results. However, when we run our QC samples, even the level 1 or the low control, most commercial controls at the lowest level have a platelet count of around 70 to 80,000. And we know that is not the area of concern for the clinician. The area of the concern for the clinician is typically less than 50, closer to the 20 and 10,000 range. This is where we need to run our samples, define what is acceptable, share it with our clinician so that there is a complete trust and we bridge the gap to what is acceptable difference on our analyzer for certain clinical scenarios. Now, this is the last study, again highlighting something which we recently faced last week. A patient had a hemoglobin of 8.7, had an infection with neutrophilia, 23,320 count, 80% neutrophils. Anemia, which was severe, severely microcytic hypochromic, 54.8 MCV, RDW was high, and then this was the platelet count given by the analyzer. The platelet count when we ran first by impedance was in lakhs, 26 lakh 80,000 given here. We also ran this sample in the optical method because we identified a problem in our impedance count. So if you carefully see, two things are happening. One, the RBC curve is not ending at the baseline. It is moving into the platelet region. Immediately you recognize there is marked microcytosis, 54.8. Okay. So if you see carefully again in the platelet histogram, this seems to be part of the RBC curve, whereas this component on the left-hand side, I might use a laser pointer here. This component on the left-hand side is actually potentially the platelet area. This potentially almost is half of the RBCs coming into the platelet. If you see the RBC count over here is 5.5 million. So if half your RBCs or maybe 40-50% of the RBCs are coming to the platelet, you are talking about 2.5 million RBCs being counted at platelet. Look at the platelet count, 26 lakh 80,000. That is nothing but 2.5 million RBCs have gone into the platelet, giving you a completely false platelet count. This is easy because you saw the smear. There were very few platelets. You ran an optical platelet count. The count was 1,17,000. The challenge is not every lab will have an optical platelet counter available. This is where identifying the histogram becomes abnormal. This is an extreme case, but you will get a case where the platelet count by the impedance is 2,68,000 and the actual count may be 1,17,000. Again, that is also maybe because of microcytic fragments. The peripheral smear really helps you a lot. There was, marked anisopoikilocytosis, a lot of microhypocells, a lot of acanthocytes, macrocytes were also there in the background, nutritional deficiency anemia, and then there was giant platelets and reduced platelets on the smear. So all in all, the take-home message would be thrombocytopenia is very, very common clinically. Peripheral smears are very useful, and picking up the phone and communicating with the clinician, I personally feel is most useful in such scenarios. With that, I would like to thank my whole team and like to thank all the people here for their patience listening, and would like to hand it over to Agarwal sir and the discussants.
Thank you, Kunal, for that wonderful presentation. Lot of practical tips. Your case discussions were excellent. We'll give you rest for 5 minutes. We'll just give the answer to the quiz for everybody and then come back to you for the Q&A session.
Sure, sir. Thank you.
So coming to the Sunday quiz that was put to you. This quiz was related to thrombotic thrombocytopenic purpura. You were given 11 statements, of which one was false, and you were to send the number of that false statement to us. So these were the 11 statements, and we'll discuss them because this is a part of educational exercise. Sorry. Acquired TTP accounts for 90% of the TTPs is a correct statement because the congenital TTP accounts for about 5 to 10% of patients only. Inherited or congenital TTP, secondary to mutations in the ADAMTS13 gene, usually presents in the childhood, but it can present for the first time when pregnancy is the trigger factor. You know that in pregnancy, the von Willebrand factor level goes up, and that acts as a trigger for a patient to overtly manifest. So this is correct. About 20% of congenital TTPs present during first pregnancy in a woman. The third statement was in acquired TTP. In acquired, you expect the antibody to the ADAMTS13 to be documented. But in 25% of subjects, you are not able to document. This is a correct statement. And there are plenty of reasons. Some cases may remain unexplained. In other cases, there are plenty of reasons for which this kind of antibody may not be detectable in the lab, or the antibody may not exist. There may be various kinds of acquired problems because of which the ADAMTS becomes overactive, becomes underactive. ADAMTS13 regulates the VWF multiple size by acting at the A2 domain of von Willebrand disease. Von Willebrand factor is a correct statement. You know that the von Willebrand factor is a large factor, and there are various domains. It's the A2 domain which is chipped or cut by the ADAMTS13. So this is a correct statement. We have studies from Europe and some other parts of the world like Japan and etc. But the largest study of TTPs come from US and Canada. And both of them have shown that this disease is more common in obese females of Black ethnicity. And the peak is between 30 to 40 years, that is fourth decade of life. So this statement is correct. In fact, the Black to white ratio in US is 7:1. And all other factors have been mentioned here. The commonest site of manifestations are brain, 60%, GI tract, about 30%, and cardiac, about 20%. And therefore, this statement is correct. Some of these can be extremely subtle, just headache, dizziness, confusion, abdominal pain, vomiting, diarrhea, STT changes or other changes in the ECG or TROP-I going up. Thrombocytopenia in TTP is severe. So the platelet count is very often under 30,000. And this is a correct statement. There are patients who may even bruise or bleed and may require platelet transfusion, though as a standard teaching, one teaches that in TTP not to give platelet transfusion. But some patients may have extremely low platelet and bleed internally. As against HUS and atypical HUS, where U for uremia is a very, very important clinical presentation, patient getting into acute renal failure, patient developing chronic nephropathy, patient may needing renal transplant, and even the transplanted kidney may getting damaged if it is due to congenital complement pathway defects. Unlike them in TTP, the creatinine is usually not high. The kidney involvement is there, but it is often in the form of proteinuria, hematuria, or creatinine going up to 1.3, 1.5, 2. If somebody's got a creatinine of 10 as the presenting feature, do not think of TTP as the diagnosis. And it makes a C difference because all these are microangiopathic hemolytic anemia, but you need plasma exchange only if it is TTP. And because ADAMTS13 levels take time, most of the people have to outsource it. The results are not available to you, and the plasma exchange is imminent. It is life-saving. It has to be done on the spot. And therefore, this plasmic score, or there are other scores like French scores, they have been devised. So plasmic score is one of the best score which is used to decide that the patient needs therapeutic plasma exchange on the spot or not till the ADAMTS levels can come to you. So plasmic, this is a correct statement. ADAMTS level below 50%. Normal levels are above 50%, but below 50% is a non-specific finding. It can occur in a number of conditions. And it has been clearly shown that unless the level is below 10%, then it is not diagnostic of TTP, unless it is below 10%. So this was the false statement. Levels at 40, 30 do not really exactly give you a diagnosis of TTP. At the moment, if you stretch it, it may be 10% to 20%, but below 10% is diagnostic. The standard treatment is plasma exchange, steroids, and rituximab. And although not available in India, caplacizumab has been approved and is a standard of care for patients in US, Europe, Australia. Recombinant ADAMTS13 is not yet approved for clinical use, but is there. It's very effective for the congenital TTP, where we give plasma infusions, but it is also effective in acquired TTP, where it can override the antibody. So this statement is correct. So the answer that was expected from you was ADAMTS13 level of less than 50% is strongly suggestive TTP as the false statement. You're supposed to email number 10. So we got 7 answers. And in the order, the second was Dr. Naved Tamboli. Third was Dr. Sharifa Mai Sarah Sayyed Azim. Next was Dr. Sumit Mirk. Next was Dr. Bilal Qazi. Next was Dr. Amit Khurana. And the next was Dr. Sasitha Satyanthan. We got about 50 replies, but only 7 were the correct replies. And these answers came between 11:37 a.m. to 11:41 a.m. And the fastest finger fast is Dr. Giri Punja M. at 11:35. She's senior resident, DNB, Department of Hematology, Manipal Hospital, Bangalore. Congratulations, Dr. Giri Punja, and we'll send you your token of appreciation. We now come to the QA session. I request all our discussants to open their videos. If they can keep themselves muted unless they have a question to be asked. Okay, so raise hand sign, please. Yeah, Satish, go ahead.
Thank you, Dr. Kinol. Elegant presentation. As Sir said, learned a lot of facts, though we think we know everything about platelets. There was so much to learn. One simple and basic question. At what platelet count, when you see so many CBCs come without peripherals when they don't ask for complete hemogram, at what platelet count do you advise your technician to do a peripheral smear so that the pathologist has to have a look at it?
In our lab, the cutoff is 1,50,000 and below. Anything below 1,50,000 is reviewed. In normal platelet counts, if the machine is flagging or has an abnormal histogram, that is also reviewed. So we have done 2 things. One, we have tried to train our technicians, because this challenge of that 1,55,000 count, borderline normal, and still having clumps, there, if the machine is giving any flag, it is shown to us at least once, simply via message or a screenshot or something, or a printout. And then we decide whether in normals also a smear is required. Otherwise, the threshold we use is 1,50,000. However, in oncology setups, sometimes, with so many patients in that borderline range, we know hospitals where they use a cutoff of 1 lakh, but yes, I would recommend that the pathologist definitely see histograms below 1,50,000.
Great. Thank you. Thank you.
Thank you, Satish. A question from the audience. Dr. Kannan wants to know, what is the effect of cystocytes on the platelet count?
So 2 things. Pathophysiologically, when there are cystocytes, there is often thrombocytopenia almost always. That is one. Second is when there are fragmented RBCs and cystocytes are small RBCs, if the number is very high, normally the number may not be very high, but if this component of microcytic along with cystocytes, these fragmented RBCs may interfere with your impedance counts. In such scenarios, a good estimate on the peripheral smear as well as the optical platelet count could be quite useful. If the cystocytes are very small in percentage, may not always impact, but one can rarely see that happen.
Thank you, Kunal. I just want to add there, we just discussed this quiz of TTP. Yes. And there have been situations where the platelet count has come 100,000, etc. And clinically, you were thinking of microangiopathic hemolytic anemia, TTP, and you wanted to have plasma exchange. and the platelet count then affected your plasmic score. But you looked at the smear, and exactly what Kunal has mentioned, the broken RBCs were making the platelet count high. So when you are suspecting TTP, you want to do plasma exchange, platelet count comes good, beware. Okay. Arihant, your question.
So thank you, Dr. Kunal, for the wise lecture. So this is regarding a lot of adolescent and young adult who would come with thrombocytopenia and are often labeled as ITP and sometimes as steroid refractory ITP. And in those cases, sometimes you tend to think if it is an inherited thrombocytopenia, and frequently there may be no leads from the history. So in such cases, except for screening the family members, when would you resort to platelet morphology, electron microscopy, etc., or any molecular tests? And if and what would be those tests, and how reliable is the MPV in the setting of a thrombocytopenia?
So I'll answer it in two parts. The second question first. MPV is a very good parameter. As I said, mean platelet volume, as long as your platelet histogram is good and the machine is not voting it out, it's a very good parameter. Unfortunately, especially less than 50,000 is where the histograms goes awry, as I showed you, a lot of the giant platelets or platelet clumps. And that is where MPV might get voted out. So you may have to rely back onto the morphology. From a congenital condition of thrombocytopenia, inherited thrombocytopenia, not really congenital, there is not much that as pathologists we can see purely on morphology other than platelet size. So things like viscodilate syndrome, where you have small size platelets, typically the MPV will be very low, close to 8 or so. Or you are looking at giant platelets, then you can see gray platelet syndrome on the morphology where there is absence of granules. But the condition which you suggested, things steroid refractory ITP, which has been labeled for a long time. The other thing which you'd like to also see is look for other abnormalities in the peripheral smear. Sometimes we receive a marrow, partially treated leukemia, sometimes because of steroids. So that's rarely we have seen that. But what you were referring to as the inherited thrombocytopenia inevitably goes back to the clinical history, the clinical scenario, then doing tests like NGS, looking something like a RUNX1 mutation, which has been inherited, and such causes of thrombocytopenia. On the smear, on the lab side, it is extremely difficult. And, frankly, even as a referral hematology lab, we don't even get the history to why that has come. We just got the platelet count and follow-up. So that becomes challenging.
Again, if I may add a little bit.
Yes, sir. Please.
As you said, exactly, this is a clinician's domain. Because you have taken the history, you examined, you know that there are some associated, say, congenital abnormalities, which you should search for. You know the age of the patient, so you know that there is a possibility of genetic. You also know the family history, including for consanguinity. And whenever there is a resistant ITP, before doing some major treatment, it becomes very important that you look into all these conditions that Kunal talked about, starting from the history examination and then size of the platelet, inheritance, etc. Why is the patient resistant? Because majority respond. That means there may be a wrong diagnosis. And then comes the role of really the NGS. NGS should not be really, jumping at that, because you'll end up with some kind of mutations which have no clinical significance. And then you do not know what to do with it. I remember a child who was partially deaf, and then you made a diagnosis. As he said, the whole smear, there were dull bodies in the leukocytes. So then there is a clue. The radius may be absent, so there is a clue. Consanguinity in the parents, there is a clue. Parents' count was low, then that's a clue. So there are a lot of clues. And one therapeutic test which I have resorted is a challenge with intravenous gamma globulin. Intravenous gamma globulin does not work unless it's an immune thrombocytopenia. So if that works, then it is immune. Yeah, of course, it doesn't work, doesn't mean anything, because it can fail in ITP. So I have done that. It's an expensive way of proving the diagnosis. But when you're pushed against, you're planning some splenectomy or some heroic measures, it is worth it. Any more question, Arihan?
Yeah, so regarding microthrombocytopenia, so in Viscott Eldridge, so our lab says they do see like even below 50,000 counts, and then they are kind of resistant in releasing the MPV value as well because of the caveats that you already discussed. So I mean, what screening tests would you offer, or you just?
If the machine has voted out the MPV, there is no way we can report the MPV. You know, any pathology will not be able to give a manual value over there. There is no way. There are some additional parameters available on the current day counters in the back end, which gives some calculations and derived. Those are not very reliable. They've not been studied. They are very analyzer dependent. So I would not suggest that. Again, you go back to the clinical domain, as sir said, immunoglobulin levels, history, infection history. So, these are specific cases. Having said that, if you tell me that I see a peripheral smear with small platelet and recognize that it is a small platelet, it's very challenging. I need the clinical history from clinician, suspect, okay, Viscott aldridge, okay, so they genuinely look small, there is uniformity, there is very little PDW, the MPV is low. Then I may add little value to your major part of the history coming from the clinical side. The role is limited, I would say, from the platelet count perspective.
So one more question, if you permit.
Arihan, I'll again add here, eczema is extremely common.
Correct.
So never miss that. And of course, it's a sex link, so only the male child, most of the time. So male child, eczema, as Kunal said, recurrent infection, thrombocytopenia refractory. And under the microscope, these are really small platelets, extremely small platelets. So tiny, I mean, they're looking at you. Okay, your next question. Yes.
So this is in particular to dengue patients with thrombocytopenia severe. Are there any ways which can predict a kind of a platelet recovery that can help us in accelerating the discharge of the patient when our emergencies are loaded? Like you discussed the fallacies of IPF, etc. So is there any novel lab parameter or a newer RBC parameter like we have in predicting iron responses or something like that in the pipeline or something?
So we have traditionally used IPF and WBC count in our practice to predict, and IPF comes with the retic count. So if you have a trend of rising IPF while the platelets are falling, typically you say this is unlikely to be a complicated dengue. There is no marrow failure, the platelets are responding. Typically, once the IPF in our instrument goes above 10, 11, 12, we know this is sort of a recovery trend. But this requires an additional cost, measurement. Clinical, again, I would say weighs far more than that single lab value. Trend analysis of IPF is more important than a single IPF value. Third, in practice, the moment WBC stabilizes or rises back again, that is almost equivalent what we now see with the IPF, and that is available very easily. So you typically know when the WBC starts rising and stabilizing in a day or so, the platelet is going to rise. Again, these are very clinical scenarios. In one patient, it may predict and you may discharge and you may line up with a complication. So I would not rely purely on that report, but again, the clinical scenario. But we do use them.
Any more, Arihan? Okay, Archana.
Hi, Kunal. Excellent talk. Thank you. I had one question. So when you have a discrepancy between, I know you've explained it in your talk as well, a discrepant manual and automated count. So machine is giving another count. You're possibly getting a much lower count when you see the smear. You had mentioned microcytes, schistocytes. Excluding that or barring that, if you're seeing a very different count in the smear versus the machine, which one would you rely upon?
So practice-wise, 99% of the times I almost always report maybe even 99.9 my machine count. Unless I see 2 or 3 conditions. One is, when I say machine count, we have the advantage of running both the impedance and optical. So often this case, scenario which you're describing, for example, Arihan was quoting about dengue, you have lots of giant platelets, the impedance histogram is not correct. the platelet count on the smear appears slightly more than what the impedance is counted, okay, you rely on the optical count. Fortunately, in the machine we have, the machine based on the algorithm selects the right count, optical versus impedance also. And it says this appears more reliable on the algorithm. We rely on that count. Clumps, obviously, then there is no counts again. It's very rare to have a scenario where you are, I showed that the smear has lower count than the impedance count. It's typically where you have higher counts. Now we need to know how much is the difference. Okay. So if the machine count is around 50,000, your manual is around 60, 70. I would rather go back, check the histograms, recount my different areas, maybe count 20, 30, it looks almost same. We know that our count is extremely subjective. Machine is more reproducible. I would rather give the machine count, maybe right appears giant platelets and appears so much, but this is the machine count. We often see in private practice a habit where the manual count has been used to change the machine reported count with no comment in the review or smear that this is the manual count. And in the same place, there are 3 pathologists who report 3 different manual counts, and every day the platelet count fluctuates. So I would rather write both and let the clinician know this is my machine count, this is what I feel on the peripheral smear, this is what I've seen, and then take it forward, because this is challenging sometimes. And every time we may not have an answer. That's what I typically use.
Also, as you mentioned, in these situations, the optical count really helps, because sometimes when there are other, situations or interferences, so we have in fact created a separate order called optical, because we know there are some patients who recurrently are getting the accurate count only on the optical platelet. So we request the clinicians to, for those patients, at least just raise the optical platelet count, because that will give you the more accurate count.
So this is an important point. Whenever we have this scenario, in our report, we write down, this is not the routine impedance count, this is an optical platelet count. For follow-up samples, please ask for a CBC optical count at the time of request. So this way we can, follow them up from the next time point. First time, often we end up doing it for the sake of, accurate result. But next time onwards, we recommend that into our report.
Right.
Just to highlight, every time the optical is not better than the impedance. Some people say, oh, you have optical, you're the advantage. Especially in normal counts, high counts, the impedance is as good. It is actually very reliable. Even in thrombocytopenic samples, as I showed you, curve fit technology from Coulter or correct counts, if the histograms are accurate, invariably you will see very little difference between impedance and optical. So this is for the sake of students out there. It is not that one is better than the other. It is a clinical scenario. So optical is typically much better when there are giant platelets. There are conditions in low counts, like post-chemotherapy, when there are WBC fragments, where optical count can also have problems. Actually, the impedance becomes more reliable. There are no giant platelets. There are small uniform size platelets, and impedance can be correct. So bottoms down to going back to your smear and your histograms.
And one more question. So
Sure.
you mentioned quite a bit about platelet clumps. So when you are seeing platelet clumps in your smear, do you recommend that the machine count, like if it's significant, large platelet clump seen and machine is just given 25 or 30,000, do you recommend the platelet count be reported out?
So like in the case of that pools of platelets, I put a dash over there and I write C comment and I mention on the smear the platelet count appears more than 1 lakh based on the large pools of clumps. It's only when you're very, very confident. If you're talking about small clumps and 25,000, I will say small clumps cannot accurately measure. Sometimes, you gotta call how much it is. I would at the most say if the machine reported 65 with clumps, I'll tell the clinician the machine reported 65, it appears more than that. How much more, whether it is 165, 265 or 135, I cannot accurately measure with this sample. That's how I would restrict the way we approach.
Thank you. Dr. Asha.
Very nice talk, Dr. Kunal. Learned a lot. So my question is regarding immature platelet fraction. It is like something like reticulocyte count in anemia.
Correct.
So to correctly diagnose the anemia, we have a corrected reticulocyte count. So is there anything like corrected immature platelet fraction?
Not that I am aware.
Okay, Abhilasha, any more questions?
No, sir. Thank you.
Okay, thank you, Dr. Govind.
A nice presentation, Dr. Kunal. It was really excellent. And my concern is what are the clinical situations in which you encounter the pseudothrombocytosis instead of the pseudothrombocytopenia?
Pseudothrombocytosis. So one typically will be any disorder with severe microcytosis. So we see routine condition thaltrate with severe iron deficiency anemia, not uncommon because the MCV in thaltrate is 65, 70 approx, and severe iron deficiency and it goes down to 50, 55. So another rule in our lab, the moment the MCV is less than 60, look at the platelet count on the smear, look at the histogram. If it's not matching, the histogram has a problem, please make a smear, even with a normal platelet count, because the MCV is less than 60. So this is in some machines and some analyzers a reflex rule that if MCV is less than 60, run an optical platelet count. It helps, but it comes at an added cost. Again, deranged sample hemolysis, as I showed, typically it happens because the RBCs goes into the platelet. So that's the main reason I would see in clinical practice of thrombocytosis. Artifacts can cause that. You know, if you have a really badly maintained machine, poor quality sample, then you have various fragments which are being counted as platelets. But routine practice, that is extremely rare because you're typically dealing with fresh samples.
Oh, thank you.
Thank you, Dr. Govind. Dr. Amit.
Wonderful lecture, sir. I just want to know about, we have got similar to RDW CV. You know, I usually use a cutoff at RDW CV of more than 16.5. It goes more in favor of iron deficiency anemia. Similarly, PDW CV, does it at anything, any cutoff?
So there is a normal range for PDW, which will be analyzer, based on your analyzer. Okay, but then again, you need to use that with caution. So because, as I said, this is analyzer dependent. On the first slide, which I showed you, was the normal ranges, and that was the main focus. Like just again with platelet, we also need to look at the units for PDW or platelet grid or PLCR. So again, I don't use it practically in practice. If it is higher than the machine-defined or the lab-defined reference range, I am getting anisocytosis. Okay, I don't have an absolute value clearly in mind because we don't use it routinely. If it is high, it is anisocytosis. You look at small and giant platelets. Again, typically in dengue, you will have that. So that's one common scenario where you see that. But there's no one limit which I use. Okay, above this is significant or below this is significant.
Any role of platelet index, PI?
So there is, I am not sure what this platelet index refers to. Is it the same as PLCR or something else?
Some laboratories, they use platelet index also.
There are so many newer parameters coming across in so many different instruments. So I would say use judiciously. Some of them are extremely useful, but they need to be validated instrument to instrument, analyzer to analyzer, some within the same analyzer even after preventive maintenance. So I have not come across this parameter, but I'm sure there might be something interesting there to learn.
Thank you.
Thank you, Amit. Dr. Arihat.
So this question is with reference to DITP or drug-induced ITP. So again, I understand that a lot of it would be a clinical diagnosis, but sometimes we get consults where the patients are on multiple drugs, or if we have to use it, say, in a research setting. So there are ISTH recommendations for demonstrating those drug-dependent antibodies using a flow-based assay or a EIA. So is there, I just wanted to learn, is there any standardization or is there any reference laboratory in the country that gives a laboratory diagnosis of a drug-induced ITP?
I have practically no experience on the assay you are talking about. Maybe sir knows if any lab is doing such assays. I know there are some platelet clopidogrel based assays. There are some assays available to detect antibodies theoretically. There are some definite flow-based assays which are used in such scenarios, but I have not come across in clinical practice.
Like HIT, we offer a laboratory test, but
yes. Again, it's a very basic screening test even in HIT. And the specific tests are difficult to come by, given the rarity of the scenario. And again, as I would say, it's such a very important clinical scenario. If you wait for the result, you might already be late. So while the assays are there, sometimes the clinical judgment weighs far more importance.
Thank you.
Thank you. There are a couple of questions for the audience. One is a repeat question. Snehalata Verma wants to know what is the best method to get the correct platelet count.
Again, a very robustly maintained cell analyzer, cell counter, in absence of clumps on the smear with a normal platelet histogram would be the best method. As I said, impedance and optical, depending on some clinical scenarios, may change. Definitely an automated count from a good analyzer is what I would weigh on, with a good peripheral smear backup. That's the way I would put it.
Sure. Last question is Dr. Vinu Balaram. What is the clinical relevant cutoff of platelet count in pregnancy in the 3 different trimesters?
So I would like to take your help on the same.
All right, so platelet count drops with the increase in the trimester. It's highest in the first.
Yes.
Because there is a hemodilution during the second trimester, the platelet count goes down by about 10 to 20%. And in the third trimester, you have about 5 to 11% incidence of gestational thrombocytopenia, where the count can go down up to 80, 85,000, maybe a little bit even more, but never below 75,000. So again, clinical judgment, looking at the whole woman, no hypertension, no preeclampsia, no eclampsia, nothing to suggest HELP syndrome. You go into all those details, and then you say that this 85,000 is just healthy, absolutely healthy, normal woman in third trimester. This is gestational thrombocytopenia. So overall, it keeps going down by 10 to 20%, lowest second trimester, and in third trimester, additional problem of gestational thrombocytopenia, which is, no one knows the exact mechanism, is often taken as physiological.
Thank you, sir.
Okay, I see a couple of raised hand sign, but I think that's because they have not removed the raised hand. But if you have questions, go ahead. Okay, there appear to be no questions. Then in that case, Kunal, thank you very much for sparing your valuable time, preparing this talk for us. You educated all of us tremendously, a lot of practical tips, and I think that will help the patients ultimately.
Thank you so much, sir. Thank you so much.
Thanks to the discussants, thanks to the audience, and have a wonderful afternoon with your family. Bye-bye.
Bye. Thank you, everyone.